Hello everybody and welcome to the Safer Everyday event. Welcome to those who are on Teams, welcome to those who are in the room at the Gateway Club. My name is Vicky Tucker, I'm the Quality Improvement Manager within the Quality and Safety team and lead for Safer Everyday. Today we have two presentations being shared and we're talking about flagging up quality initiatives. So two presentations being shared, both of which are from our colleagues in the Adult Disability Services. The first presentation is going to be shared by Stephen Lee and Joe Penny. Joe Penny is part of our team, but background is in learning disability nursing. And Stephen Lee is a positive behaviour specialist lead. And they will be sharing some work that they've done using Ulysses, the incident reporting system. And then that presentation will be followed with Dr. Julian Morris, who is the clinical psychologist within the Community Disability and Learning Disability and Autism team, again within Adult Disability Services. And he will be sharing something known as STOMP, Stop Over-Medicating People with Learning Disabilities and Autism or both. I'm going to hand over straight to them. There's nothing further really for me to share other than to say there is opportunity for questioning. Thank you for coming along again. Questions will be taken in the room and for those in Teams, please put them into the chat. I will then share them at the end of each presentation. I will share somebody in the room and then somebody, any in chat, I will share out loud for people to then, for the presenters to then answer. Thank you very much. And I'm going to hand over to Joe and Steve.
So we're here to talk about some initiatives we used with the Ulysses incident report system and how we collected some additional data. So we were looking at violence and aggression or behaviours of concern incidents, and this was because it was one of the top priorities for HSC. We also looked at the best practice around the UK Restraint Reduction Network. We were reading this guidance and seeing how HSC could look at this and implement it, and we realised that we weren't really collecting the data needed to be able to demonstrate that we were looking at restraint reduction. We were looking for ways as well that we could empower staff to request more after-action reviews as a form of debrief following incidents, and how we can demonstrate we were looking at the STOMP initiative, which Julian will cover later in more detail. We had already implemented some questionnaires on Ulysses. We'd done a dysphagia one for adult disability, so we'd learn how we could make it very bespoke to areas and how we could get this triggered by using certain departments and cause groups. And we wanted to see if we could capture more information and trends around the incident reporting. So what we did to start with is we looked at the different areas within HSC and could we use the same questionnaire across HSC or would we need more bespoke questionnaires? So I spoke to different leads within different areas of HSC, so mental health, children's, acute and adult disability, and it became apparent that we would need different questionnaires for different areas. So for that reason, we targeted adult disability because they had quite a high proportion of behaviours of concern incidents. So then Stephen and I worked together to start developing a questionnaire of what sort of questions we were going to need. So we spoke with the Ulysses administrator of how we would devise this questionnaire. We tweaked some questions, so we realised we needed yes, no or multiple choice answers to be able to extract that data later on. So we tried to make sure we had very few free text boxes. But if we needed an other box, we did put those in, but we made sure people could tick an other so that when we extracted that data, we knew. We also had to change some questions and look at, so we had one for intensity, how intense was the behaviour being displayed? But we had to change that because it became very subjective of what the reporter felt would be the intensity of it. So we did lots and lots of little tweaks at that stage. We then communicated to people across adult disability that this change was coming, this incident questionnaire was being implemented, and we did that for a watch out for notice. And then once the questionnaire had gone live, we then reviewed the responses to see if there were further tweaks needed, and there were. So we needed to make a lot of the questions more specific. So we added more multiple choice answers, and we removed some additional free text boxes because we just weren't getting the data we thought we needed. And that's an example of the watch out for notice that went across adult disability. It's not the greatest quality on there, sorry.
So when we're looking at what did we achieve, so what we had previously with the system was we had a total number of incidents each month and over a full year. But what we felt like that wasn't telling us enough, so we wanted to delve a bit deeper by developing some of the questionnaires around this. With this alone, we were starting to see in some months there were some peaks in incidents of behaviours of concern, so it did help us explore those months what could have been happening across the service. But with the questionnaires, we wanted it to be a bit more specific to gather more data around that. So some of the findings that we had, so first and foremost, we wanted to see the different types of behaviours that were happening in the service, and the main reason for this is it helps you to identify level of risk across the areas. So as we could see, the 4 main forms of behaviours have been physical aggression, verbal aggression, self-injury and property destruction, with physical aggression being the most common form of behaviour in our service. The other thing, as Joe mentioned previously, one of the things that inspired this was around restraint reduction and STOMP. So we wanted to look at the restrictive practices across ADS. So this is looking at chemical in terms of PRN medication for the purpose of behaviour management and how frequent that's happening across our service. So throughout 2021, in 10% of incidents, it was identified that PRN was used. Physical intervention. So as we've seen, physical aggression is the leading form of behaviour, but also self-injury. So with a lot of the physical intervention, a lot of those interventions were around self-injury to make sure people were kept safe. And as we'd like to see, mechanical restraint, so using a device to restrict someone's movement for the purposes of behaviour management, that was at 0% across ADS. Other things we wanted to look at was around triggers. So we wanted to see staff's understanding and getting them to identify what triggers could have led to some of the incidents that were occurring, because sometimes the incident reports alone weren't telling us that. So we had specific questions with certain themes that we often see across the service. So as we see here, physical health and pain is the leading trigger across the service, but also mental health. And what that helped identify with us is to look at what does it look like when a person is deteriorating physically versus just simple like some other triggers, like there was a communication breakdown and the person has an incident. So it helps us to start to distinguish what people are identifying as triggers. And also when looking at mental health, some of our guys have learning disabilities and mental health, some don't have mental health conditions. So that got us looking at people's understanding and what they seen as mental health and what they seen as simply challenging behaviour. Another common things across our service is demands put on people, instructions or requests, communication breakdown. So a lot of our guys have communication impairments. So that's quite a common one. Changes to routine. So for a lot of our guys with autism, sometimes they like to know what's happening in their lives, and when that's broken, it can lead to incidents, items or activities not being available, looking at the environment, so on and so forth. Other things we wanted to look at within this was also organisational factors. So often we look at the more common behavioural triggers that happen within incidents, but we wanted to explore things like staff training. We wanted to look at staffing levels, and also the environments that people were living in. So what we seen with staff training was the majority of staff identified that they did not require further training following on from the incidents. However, nearly a quarter of staff did identify a training need. So that helps us to look at what sort of training is needed across the service. It's not always behaviour support. Sometimes it could be things around communication and maybe some further education around mental health. Also looking at correct staffing levels. So with like staff turnover, as in most people's services, it can be a bit of an issue. So we wanted to look at how that was affecting incidents of behaviours of concern. What we seen was, surprisingly, the majority identified that there was enough staff on shift. So that didn't seem to be much of an issue, thankfully. And also when looking at environmental impact, this was quite an important one for us, because when we start exploring the environments that people are living in, we can start to see, is there things that we can change within their environments, or maybe do they need a change of environment completely if there's nothing we can alter. Other things, we wanted to look at what types of plans were in place to manage some of our incidents. So we wanted to look at how many incidents, how many care plans were in place. So for 67% of incidents, there was care plans, risk assessments, and 66% positive behaviour support plans. We also looked at following incidents. So we wanted to look at pre and post. So after action reviews are offered to staff. So they identify it within the questionnaire, and following that, the quality and safety team offer them the opportunity for an after action review. And this allows people to have a debrief following incidents. And what we found was 33% of staff utilise this process, which I think more people might utilise that going forward, because it was a relatively new process, and I think some people didn't necessarily understand what it was about and what they were saying yes and no to. So in summary, the main things from developing the questionnaires, we helped to identify services with the most need, so we could target and provide bespoke training. Monitor levels of restraint and restrictive practice service-wide. Ensure plans were put in place, or if there was also knowledge of plans in place. Because what the questionnaires helped us to see was, if there was already plans in place and someone said, no, there's not a plan, it helps to identify there's maybe a knowledge gap. Learn about staff's understanding of triggers as we went through them. Learn about organisational factors, and also responding to the staff needs for debrief.
So going forward, we looked at where do we go now we've gained all this information. We want to create more questionnaires if they'll be beneficial to different areas, even if they're different themes, if they can collect different types of information. We want to link it to PBS competency training so that it becomes more real for staff. Stephen, I don't know if you want to say more about the competency training, because you're doing that.
Yeah, so with the competency training, so what we're trying to roll out is to kind of move away from classroom-based training and more on-the-job coaching. So with the questionnaires, it kind of helps to see areas of training needs, so we can make training more individualised and bespoke across adult disability.
We're considering looking at the questions on restraint. So it's not just asking, was physical restraint, chemical or mechanical used, it's breaking it down further. So if physical restraint is used, actually getting staff to say what level of restraint, what type, what was duration, so that as an organisation, HSC can see if we're being proportionate in what we're doing. We've rolled this questionnaire out into another area within children's, which supports people with a learning disability, so it's transferred quite nicely into that area. So we're now gathering data that came out February this year, so it's quite new, but already starting to collect data in that area. As I've said, developing new questionnaires in other parts of HSC if it will be beneficial, and reviewing the current questionnaire on adult disability to make sure the questions remain relevant or if they need updating. And that's it.
Questions?
Are you going to sort of repeat the questionnaires or sort of collect the data on the questionnaires on an annual basis, so you can sort of monitor things like restraint across the service and stuff?
Yeah, so what we want to do is kind of compare year on year, so we can start to see, so for example, what was it, 10% was a physical restraint or chemical. So then when we look at 2022, has that increased or decreased? And if so, we can explore that a bit further.
And also, once a month, we compile this information and take it to the Adult Disability Governance meeting so it can be explored there. So Stephen does a little write-up so we can see if trends are changing. And then we're going to start also looking at it quarterly with an adult disability to see if we can see the trends changing every few months as well, to explore the incidents a bit more.
I'm just interested on the slide you had that with contributory factors. There was a large percentage of those around staff training, and I know you mentioned that some PBS training, etc. But how much do you think contributed to the behaviour of concern due to a lack of training? I.e., did it incite the behaviour, or was it lack of ability to manage the behaviour that you measured?
Yeah, I think in some circumstances it was quite clear there was a training need. In a lot of cases, it was also being knowledgeable around the plans that were in place, so care plans, risk assessments and PBS plans, because what we'd see in incidents, you can clearly see whether a plan was followed, and spotting the triggers and all of that. And some of that is training need, and some of that is more on the job kind of duties, like reading your care plans, reading your files about the service users you're supporting. So yeah, there is definitely a training need across the service, but not necessarily in all cases. Sometimes they've had the training, they just need to kind of look at what the plans were more individualised, because with the training it's quite general, so it's not individualised to people at the moment, and that's partly why we want to move away from generic classroom-based training and move it to on the job, so it's a bit more person-centred.
Does your training reflect types of triggers?
Yes. Yeah, so we would look at different types of triggers, particularly with people with learning disabilities. So a lot of the triggers that we identified for the questionnaire were common triggers we were seeing across the service, just from knowledge of working in the areas and seeing the incident reports that were coming through. I don't know, does that answer it?
Thank you.
There's currently no questions online, but I would just like to sort of say, from a Safer Everyday perspective and sort of quality initiatives and improving what we do and how we go about looking to improve practice, it's really clear and evident that you have followed the principles around the PDSA cycle, plan, do, study and act. You've made small tweaks, small changes to what you've been doing, which is really refreshing. And this piece of work, whilst it was looking over 2021, all in all, how long did it take you, can we remember, to start from inception to getting it in place?
So I think, did we start it in maybe October, November 2020?
Only a couple of months.
Yeah.
A couple of months.
So within that sort of time frame, you did a lot of tweaking within a really quite a tight time frame. We were able to get that information out. So just again, well done from that perspective. And that ongoing need for continual revisiting and re-evaluating the tools, re-evaluating the information you're trying to gather and the trends that you're trying to identify is really, you know, in full essence all about Safer Every Day. So I'd like to say thank you for doing that. I just want to double check that we still have no questions on here. So
I might have one more. That's
Julian,
okay.
feel free.
Sorry, it's just so I've noticed if we're thinking about some of the outcomes, desired outcomes, they're similar to some of mine actually, which is in terms of things like care and support staff feeling more confident in understanding and managing behaviours of concern and incidents. But I've realised I haven't got a way of sort of trying to tap into whether that's actually happening or we're getting that as an outcome across the service. Have you sort of got anything in mind about that, or are you using anything as part of the competency framework or anything?
Like measure it, do you mean?
Yes.
Yeah.
How confident people are in sort of their understanding of and management of behaviours of concern.
Yeah, so we have it in the new PBS competency package that we're looking at, so it does cover those different aspects about people's knowledge and confidence. I think an area that we could look at is around the after action reviews and measuring maybe the impact of those around staff confidence following a debrief and some learning points maybe. So that is an area for possible development.
Get you further, just see if we can link it into some of the STOMP stuff as well. Yeah. Thank you.
I would also just add as well, because I know we talked about could we roll it out into other areas. I know we initially, because I was part of some of those conversations in the early days around whether we could roll it out in some of mental health services, and whether there are some areas, even like within the ED particularly, would be somewhere that we could perhaps look at something similar to the existing behaviours of concern questionnaire and how we get that data, and or alternatively a questionnaire around true violence and aggression, and maybe with your expertise there, Stephen, albeit from a positive behaviour perspective, which is a really good thing, we could perhaps look at how we can devise something for the organisation around violence and aggression in general, rather than specifically behaviours of concern. So that's another piece of work that maybe we can pull on your skills with. Okay. Anybody else got any other questions before we go to Julian, who will share? Julian, are you okay to push your slides on to
Yep, I think so.
where you need to get to?
Hi, so yep, I'm Julian Morris. I'm the clinical psychologist in the Community Learning Disability and Autism team, and I'm here to talk to you about... Sorry, there's more.
Keep going.
About an initiative called STOMP, which is stopping the over-medication of people with a learning disability, autism, or both. What STOMP is it's a national project that developed in the UK. It started off with NHS England, but it's now sort of covers the four countries of the UK. And it's a sort of, as the title suggests, aimed at stopping the overuse of psychotropic medication for this particularly vulnerable group of people. And I'll explain a bit more in a second about where that's come from and why this seems to happen. Essentially, though, it's about promoting the best ways to support people, sort of both clinically and in terms of their everyday care and support needs, so that they can stay well and have a good quality of life. Just for those who aren't clear, or for a reminder for those who it's not part of their everyday work, psychotropic medications are medications aimed at changing how the brain's working. So they're looking at influencing mood, thinking and brain functioning. Typically there's evidence-based use for psychosis, depression, anxiety, sleep problems and epilepsy, and people can report good outcomes from them across the board for associated conditions. What's been found though is that psychotropic medications get overused in some groups, and that use seems to be inappropriate. So about 10 years ago now, there was a increasing recognition in the UK again about the overuse of psychotropic medication in older adults. So it's got this disproportionately high number of prescriptions for medications, sort of the anomalies with that seem to be that psychotropic medication was associated with increased mortality, increased risk of falls, increased risk of strokes, and didn't really seem to have the desired impact on many of the target behaviours and target symptoms. So you had this sort of difficult picture arising, and there was based on that, a national call to action to try and change practice in the area, and they got, I can't quite remember the details, but quite a marked and noticeable reduction in the amount of psychotropic medication being used in older adults, without negative impacts on the clinical outcomes and some associated positive outcomes. What we've seen on the basis of a couple of reviews of sort of serious incidents in some learning disability services, so these are inpatient units in the UK where there are a couple of high profile, usually documentaries from BBC or ITV, exposing very poor practice. And on the back of the reviews of those, we found that actually there seems to be similar prescribing practice and overuse of psychotropic medication in the learning disabled population. And across both these groups, actually, it tends to be used as interventions for what's called behaviours of concern. Stephen and Joe talked a bit about this in their presentation, but it's behaviours of concern are behaviours that are sort of seen as culturally inappropriate and might impact on somebody's ability to function in the community. And they're things like verbal aggression, physical aggression, sometimes sort of some self-injury or some property damage, for example. And for the purposes of STOMP, what we're particularly interested in is these behaviours outside of the context of a known mental health issue, because that's where there's not really an evidence base for the use of the medications. So that's sort of what we're looking at in terms of stop, and that seems to be where there's the overuse that isn't appropriate. The reason it's an issue is because people are exposed to the risk of side effects, some of which are serious, and with little or no benefit on the target behaviours that are causing the issue. And if we think about side effects, some of the long-term ones are associated with some of the other sort of chronic health issues that we know are impacting the population as a whole, so sort of obesity, diabetes, for example. What it also does is overshadow the use of clinical interventions that are known to be more effective. So if we look at sort of clinical guidance, many of the psychosocial interventions, positive behaviour support, which Stephen does, some of the psychological interventions have got better outcomes, either used in parallel with or instead of psychotropic medication, but they're often overlooked and not seen. And if psychotropic medications are used, often people aren't then getting access to the interventions that do seem to have a better evidence base. Also, what tends to happen is once people get started on a psychotropic medication for a behaviour of concern, it doesn't really get a proper review. So people end up on it for a long period of time, which increases those risk of those chronic side effects and also increases the risk of polypharmacy. So what happens is if a behaviour returns later on, people either get an increased dose, or if somebody's at the maximum dose, they get another medication, which increases the risk of other side effects again. With NICE and best practice guidance, it says that psychotropic medication should only be used if psychological or other interventions alone don't produce positive change within an agreed time. Treatment for any sort of mental health condition hasn't led to a reduction in the behaviour. So if you're targeting something else that's happened that you know is there, like a physical health problem, and that's not made the behaviour go away and you're very stuck, that's when perhaps some psychotropic medication might be indicated. Or if there's an immediate, very acute risk. So if somebody's sort of immediately thought to be of high risk of harming themselves or others, there might be some psychotropic indicated for the short term. None of this is particularly controversial. Sort of these things sort of generally are accepted in practice, but still we've got this disconnect between what seems to happen and this guidance. We're still developing our understanding of quite what goes on and why the prescriptions seem to happen. But themes that seem to emerge from what we do know are that what happens is somebody presents in a crisis. A&E is a good example. You've got somebody with a learning disability or autism presenting in a crisis with some carers. Everyone's very distressed, and there's perhaps a limited understanding of behaviours of concern in an A&E setting, because it's not primarily what A&E is for, and people are desperate to help. And so what people do is they default to what they think might help, which is some medication. And that's so one thing that seems to happen is that people are in a crisis setting started on some medication, and then somewhere along the line it doesn't get reviewed. So once you return to primary or secondary care, it doesn't quite get reviewed and you stay on it for a long time, whether or not it's having an impact. Other things that seem to happen are that at various parts of the health and social care sector, there's a limited understanding of what alternatives are, and that there are alternatives available. Other things that have a better evidence base for decreasing the impact and the frequency of behaviours of concern. And so people default to, well, you're presenting with a behaviour of concern, therefore I'll prescribe some medication. And similarly amongst carers and other people in sort of caring roles such as family, there's a limited understanding of what the different approaches to behaviours of concern might be or where they're coming from, and so there's a lot of pressure placed on services to do something, particularly prescribe medications. You've got these different sort of things that seem to come together to try and sort of lead to this picture. And what we sort of get to is this stage where we've still got sort of 35,000 people in the UK with learning disabilities, and this is adults only at the moment, who are prescribed a psychotropic medication in the absence of a mental health diagnosis. So it's primarily aimed at this behaviours of concern where there isn't really a substantive evidence base that it's going to make a difference. And people end up on these for a long time. Since this data is a few years old now, but it hasn't been updated in terms of national figures for the UK, but it is recognised it's probably an underestimate, and also now that actually children are also should be included in this figure as well. So that figure is actually much larger than's represented there. So I'm relatively new to Guernsey. I've been here, well, relatively new, it's two and a half years now. So I still feel relatively new to Guernsey. But this isn't just the UK problem. It's something we actually see across sort of similar populations in, for example, Western Europe, the USA, Australia. It's a very similar pattern that occurs. And Guernsey is no different. So when I've come here, I've seen exactly the same thing. When I arrived, people were already talking about the need for a STOMP initiative. I don't know why that's there. So the aims of STOMP. So we've sort of set a STOMP program up in the past couple of years. The aims are to improve the quality of life of people with a learning disability, autism, or both. Make sure people only receive psychotropic medication for the right reasons in the right amount. Improve understanding of psychotropic medications and when they should or should not be given. Improve understandings of alternatives to medication. And make sure that people with a learning disability or autistic adults are involved in decisions about their treatment. So much more informed, sort of person-centred approach to healthcare. So where's it got to? So STOMP started in the UK in 2015. It was an initiative led by NHS England, but with the support of a few of the professional groups, the Royal College of GPs, Royal College of Psychiatrists, British Psychological Society, I think the RCN were there, and I think it's called the British Pharmaceutical Society, so the pharmaceutical body. And what those professional bodies have done in particular is work very hard to raise awareness of the issue amongst their members. NHS England's worked with some other organisations to try and raise awareness amongst health and social care providers and more widely in the health and social care system. As part of that, a number of resources have been developed, both for professionals, for carers, and for people with learning disabilities and autistic adults themselves. And an additional program's been added in for children, which is called STAMP. They've tried to keep a theme. So that's there as well. However, I think overall progress has been patchy. So national data's not quite sort of followed through. They've not kept track of quite how many people across the board they think have been supported to reduce medication appropriately, or what those outcomes have been. Very much is dependent on local initiatives, and that's largely driven by local interest from individual professionals. Some areas in the UK have got slightly more robust systems, so there's a couple of areas with like specialist pharmacists, and that has a really big impact on getting outcomes. But it's really difficult to get an overall picture, and I think patchy is probably a real sort of genuine way of trying to understand what's been going on. No clear national data, I've already said. I'm not quite sure why that is. I think they struggled to get the data initially, and there was maybe some slightly stretchy sort of statistical interpretations of what they had. I don't think it's an unvalid picture, but I think it's quite hard to do comparisons later on. But they sort of don't seem to be producing national data clearly to sort of show where we're going. But what there has been recently is a recent refocus by NHS England in particular, and it's in the long-term plan. Again, though, there's a degree of ambiguity. I think it was put in the long-term plan because there was a recognition stuff needed to be done, but how that's going to be operationalised is still very, very vague. So there's things that need to be sort of improved upon in terms of what's actually going to look different. Just some examples of some of the resources I mentioned that have raised awareness and sort of given some practice guidance. So this is from the Royal College of Psychiatry and something called the Learning Disability Professional Senate, which is an umbrella body of different professional leads. So they all get together nationally and try and sort of steer the direction for professionals, and it's a group involving carers, NHS England, various government representatives. Quite an effective group in many ways, and this is one of the resources they've produced. Challenging Behaviour Foundation is a charity for people with learning disabilities, predominantly aimed at family carers of people who have quite a severe learning disability and engage in quite severe challenging behaviour. but they've also been involved and set up a medication pathway and resource for family carers to try and help family carers navigate how to get appropriate medication only for the people in their care. And VOG is it's the grouping of voluntary agencies that work predominantly in this sector. And again, they've sort of been quite heavily involved in getting health and social care providers, which are much more disparate in the UK, to be involved in this initiative, and also for people to know what to do, for example, when they're going to see a GP or a health specialist. So in Guernsey, what have we done in Guernsey? So Adult Disability Services, we've been piloting a pathway between psychiatry, myself and Positive Behaviour Support, led by Stephen. We're hoping to engage with GPs. That was one of our big early goals, but COVID's been one of those things that's really disrupted that, and we've had this pattern of repeatedly building momentum and then losing it for various things. I'll talk about the challenges in a minute, but we haven't quite got there yet, but it's one of our medium-term aims. We're using a range of measures through a person's journey on the STOMP pathway. So what we've set up is a specific pathway. So we're sort of making sure we're collating data for people who are where we think we should be reducing medication because it's being overused. And we've got a questionnaires on frequency and intensity of challenging behaviour, quality of life, and side effects of medication. And we're trying to take those at the beginning before somebody starts their journey of medication reduction, and then at various points along the way. So we got some quite, hopefully, or in theory, quite a robust data set for how people are going throughout and at the end of that journey. And ultimately, we're trying to prevent the overuse of psychotropic medication and offer alternative interventions. And what that's essentially going to need is quite a big culture shift. I think here, like with the UK as an example of another health and social care setting, that there's very much a culture in sort of health settings, social care settings of if somebody engages in behaviours of concern, we need to try and find a medication solution to that. And it's been there for a long time, and it's something that's quite significant that we need to change. We've got a way to go yet, but starting to raise awareness through things such as this is one of those early parts of doing that. So some of the challenges. So these challenges, when I sort of wrote them down, they all feel like things that should be very overcomable. They're all quite simple in many ways, but it's just, I think a lot of this is to do with this being part of your everyday day job and something that's additional. So you've got to create an additional pathway, track a different set of data. Our electronic record perhaps doesn't help us do that in the best way possible, and some of the systems we've got don't help us do that at the moment. So sort of it's these things sort of hopefully as we go forward will continue to be overcome, but for now they've created barriers. So just completing pre and post measures in a timely manner. So getting somebody on the journey and starting those measures off has been sort of difficult, and we miss data for a lot of people. Working with our psychiatry colleagues to get a clear plan on what's going on with the medication. So we've got a consultant psychiatrist who's visiting, so comes for a couple of days a month, and we've got a day a week from a very good associate specialist as well. But just trying to coordinate time so that we're overlapping in clinics, or where sort of we know when somebody's been called to a crisis for somebody has been a real difficulty. So what happens is a plan starts off for medication either increasing or staying the same or reducing, and we don't find out until later on. So again, somebody's sort of along a patient journey before we've sort of realised what's going on. The current system we've got is around people who are already open to our psychiatry colleagues who we end up joint working with, trying to support them in the reduction of medication that seems inappropriate. What we haven't been so good at so far is identifying people proactively and saying, actually, this is our population, we're worried about this subset of the population, we should be driving forward things with this group. It's the sort of thing that once it gets going in a place like Guernsey should be very, it should have a lot of traction and keep going, but it's still been difficult to set up. And again, I think the patient record and the way we get data isn't particularly helpful necessarily on that. Yeah, and just time. So time to coordinate stomp activity has been quite difficult. And coordinating the crisis response I've already mentioned. So somebody just turns up in A&E, they're outside our adult disability context. We don't always know what's been started off and then continued in primary care at some time until much later on. So some of those we've started to address. So we've got some support time from an assistant psychologist now, Leah. Thank you very much, Leah, in the room. And that's already helping us get a bit more coordination and a bit more timely with the pre and post measures. We've got a new visiting psychiatrist starting as well, and actually that's given a bit more impetus in trying to make sure we can get some more routine time built into the slots that's got available there. So we're hoping we can carry on pushing things forward in an increasingly improved way. This is where we've taken people through so far. So we've sort of 4 people who've got a complete STOMP episode and 6 people have got one ongoing. We've reviewed another 4 people who it wasn't appropriate at the time, either because of the person, the family, or other physical or mental health issues meant that it wasn't appropriate. And we've got 5 people who we've actively identified that will be next on the list. So the 10 people, so the 4 completed and the 6 active people, they've all had at least one medication stopped or reduced. There's been no increase in behaviours of concern. And a decrease in side effects where we've been able to complete the measures. So some of those people we haven't done pre and post measures fully for, but the people we have done have shown either no change or, I think for most people, a reduction in side effects. And no impact in quality of life as well. So people aren't losing quality of life as an additional sort of red herring intervention. There's not other things happening. So what seems to be happening is that medication's been withdrawn and actually it's having, it's reducing side effects without having negative effects elsewhere. So what we're hoping to do next, continue with the pilot, make it more robust in terms of how we're resourcing it and keeping it as part of business as usual, and then it should hopefully tick along and make progress quicker and make data collection easier and easier as we're going through. We want to try and write up the interim results and submit for publication somewhere. There's not been lots of peer-reviewed stuff coming back from, for example, the UK on how things have been going there, so that should be a useful thing if we can get it in the peer-reviewed literature. And it's a good bit of advertising for Guernsey as well, where we can show that we're doing some good work here. And also try and see if we can work out a way of considering the financial impact. So looking at not just medication costs, but sort of clinical time, and also then likely impact on maybe some of the medium-term physical health impacts from side effects and where we might be sort of making indicative savings there. It's not that easy to do, but if we can try and get some idea, actually that could be quite powerful in trying to help us resource this and keep this going forward. I think, and that's it. Any questions?
Is there any financial data anywhere in the UK?
I haven't seen any for learning disabilities. You get bits of it, so you get bits for sort of cost of medications, for example, but cost of medications are generally quite small. And then you can try and work out bits for clinical time, but the problem is you're front loading a lot of the costs. So actually, like our experience is, you're putting in more clinical time to try and get somebody off the medication now. But there's some potential savings in the sort of short, medium and long term that we've got to try and take account of, and it's that bit that's a bit muddier, and I've not seen anything clear on that. Steve.
Thanks, Julie. That's really interesting. I just wonder if there's any overlap or engagement with the non-mental health and learning disability areas that you've either considered or that's occurred. I'm thinking about geriatrics, the sort of the older adult area. I mean, we were just looking at a case this afternoon where an very elderly lady was on diazepam, lorazepam, chlordiazepoxide and haloperidol for Zithmilia, and very agitated.
Yeah.
And the outcomes aren't good. You look at it and think, well, where are we going wrong? So I mean, clearly the message could do with being spread a little a little broader, and I wonder if there is a mechanism for perhaps that to happen.
We haven't got any sort of links with that sort of side of the HSC at the moment. I think they could probably readily be made and they would fit together well. And I think, as I said earlier, the sort of precursor to the STOMP for adults with learning disabilities and autistic adults was this national programme around psychotropic medication in older people, and actually a recognition that it was overused, and they managed to reduce it quite considerably in the UK. So certainly there's a good chance of a crossover, I think. Yeah.
Yeah, I hope so.
Sure.
Got a couple of questions, I'm afraid. Do you know if anyone's looking at STAMP? Because I know obviously you're looking at STOMP. Do we know if anyone from Children's Services have mentioned STAMP at all?
I don't. So no would be the short answer, but it's something I should perhaps ask about. Yeah.
And my other question is, when you're looking at reducing medication, are you seeing any physical health problems that are coming to light that have maybe been undiagnosed and would maybe have been the cause of some of the behaviours?
Certainly, I think what we're seeing is that some of the people we're recognising need to have their medication reduced are experiencing side effects, which probably or may well contribute to the behaviours. Constipation, tremor, fatigue, sort of very common ones are there. So yes, probably is the answer, I think. So we're seeing things that probably are helping maintain behaviours, and it might be one of the reasons why once we're reducing the medication, we're seeing behaviours certainly not increase and in some cases come down.
Just wondering the whole diagnostic overshadowing, stuff like that.
Yeah. The more we sort of get people completed on the pathway, I think the more likely we are to see sort of various, or maybe perhaps some different ideas about why various physical health issues have been occurring, for example. Yeah.
We have a question online, Julian, for you from Brian, and it might be that it's wider than yourself, but hopefully you can contribute. Where crisis does occur in hospital settings, are discharge summaries copied to adult disability teams, or are you reliant on waiting to hear from the information from the GP receives from the hospital?
Yeah, mostly, yeah. So sort of it's often not a clear pathway. So somebody will go in, they'll be discharged. We might hear from a carer if somebody's actively open to the service, or the person themselves. If somebody's only sort of sporadically supported by the service, we might not hear, it's not a fluent system.
No, and that is something that sort of Brian is part of our team, and something we're very aware of and have been working with sort of those who are coming into hospital for surgical procedures, elective or otherwise, on trying to improve that admission process and that journey. But we have recognised that the discharge, I think, for people those service users within adult disability who are supported predominantly by adult disability, so not those necessarily living in home environments, but those supported by adult disability, quite often are left out of the loop with regards to the discharge summaries. And I think that's something that we do need to try and improve on, because it is it's not a very smooth pathway, and you've already expressed that sometimes you don't know that person might come into crisis, into the ED, and you find out 5, 6, maybe even longer weeks down the line that's actually happened, and interventions on those medications could have been reviewed and things.
Yeah, I think the care and support systems around individuals are often very complicated, and so what I think there's often a hope or an assumption that if somebody's in A&E, actually the information about that experience will get out very quickly and very easily. So people are thinking, oh, that's great, there's carers involved, and that information will get through to relevant professionals. But it just doesn't work like that, and that's not a fault of a system. That's just because of the complexities of the system. So if that could be streamlined or made easier, that would probably be helpful.
We have a colleague from the acute, I think, who's currently typing at the moment online, so we'll just wait and see. She might be able to sort of advise where we're at or what we could do about that, working together collaboratively. The new EPR system, when it comes in, hopefully will help as well, because it seems like they might be talking together a lot more readily and a lot more robustly, so that should probably help as well. So Claire Rigler from the acute, she's one of the lead nurses within the acute, has said, in acute we do not currently have a standard discharge summary template or distribution, but it is something we could look at. Yeah. So that's something I think we should and are about to embark on a pre-assessment for elective patients.
Okay.
So again, something that we could definitely pick up under Safer Every Day and start to move that forward, I think.
I think sort of one of the things that has worked quite successfully in a couple of areas I've known in the UK is sort of trying to work more closely with colleagues in, for example, A&E is a good example, and trying to sort of think about different pathways that might be available to someone if they're turning up and presenting with distress, which is behaviours of concern, and whether, when it's unclear whether it's a mental health problem or not.
Yeah.
And that's sort of both within the A&E setting itself, and also our colleagues in psychiatry are often sort of on call.
Yeah. Somebody else online has asked if this is something that could be part of the discharge review policy currently being reviewed by Joe. Penny.
Sounds a great idea, Joe.
That's your colleague, Joe. You can talk to her later.
Did you have a question as well?
You pretty much answered it already, because I was going to ask if you think there could be any kind of initiative that you could liaise with departments such A&E, but you already mentioned that.
Yeah, very much so. And I think sort of one of the things is, as people become more aware of it, those links become easier. It's one of the difficulties is starting to form those links now when it's sort of you're doing other things, and also the other service might not quite be clear the advantages or why. Everyone's quite keen to make links, but there's only so many things we can do in a day. So I think it does help, but there are things that tend to build up over time. Yeah.
Absolutely, thank you.
Anybody else? I don't think there's anything else going on online for questions. But thank you, Julian. I collared you for another presentation later in the year. Would you like to just sort of maybe share what that might be about? Can you remember?
No,
What was the other topic you were going to share with me?
I've forgotten.
Joe, can you remember?
I'll be back later in the year for another
He's back later in the year.
stunning presentation.
Let's just put him on the spot, and I can't remember either. But yes, Julian is going to share another piece of work that he is working on that he clearly has forgotten, but he's working on it. But he will be with us later in the year, which is really good. I'd like to just say a big thank you to Joe and Stephen and to Julian for sharing today. Really good pieces of work that are going on within Adult Disability Services, so thank you very much. Thank you to those who've been here in person, thank you to those on Teams. Let's continue to spread the word, because there are some really good initiatives going on. We need to consider more how we get some more measures and some more data for what you're doing, because I think it is crucial, and those financial impacts sadly are what motivate a lot of people, so we need to figure something out about that, I think, and I'm quite happy to sort of put my head together and see what that might look like. Can you just move to the next slide, Julian, as soon as you've got the control?
Can we do a round of everything?
Yes. I did say thank you, but I didn't do the round of applause. Dates for your diaries. We've got the Quality Improvement Clinic on the 8th of June, which I'm hoping that's right, Jenny. We should be in a position to present the pressure ulcer quiz results. So for those of you in HSE, know that there was a pressure ulcer quiz that was shared globally across all areas to see and understand the level of understanding we have around pressure ulcer management. So that should be quite interesting, I think. It might be quite telling. And then the Safe Everyday presentation sessions the next dates are the 24th of August and the 15th of November. Same venue for all of them, between 2 and 4, so it might be slightly longer than 3 o'clock depending on how many presentations are taking place. So yeah, please do come along, please support, and thank you very much.
Thank you.
Thank you.